Good morning, friends. Today we are on a 13th day of reading Oxford Handbook of General Practice, and I'm Dr. Sesha, your study buddy for preparing for MRCGP AKT exam. And today we are starting adrenal disorders, page number 338, from topic endocrinology. Disorders of the adrenal cortex. The adrenal cortex produces three classes of steroids: glucocorticoids, mineralocorticoids, and sex hormones. Like cortisol, aldosterone, androstenedione, testosterone, estrogen. Disorders result from disturbance in production of these steroids. Cushing syndrome. Majority of cases, Cushing syndrome is iatrogenic, caused by exogenous administration of prednisolone or other corticosteroids. Non-iatrogenic Cushing's is much rarer, with an annual incidence of 1 in 2 per million. Females more than male predominance. 80% have a pituitary adenoma which secretes adrenocorticotropic hormone causing hypersecretion of glucocorticoids and sex hormones, which is Cushing's disease. 20% are due to ectopic ACTH secretion from other tumors, example small cell lung cancer, or hypersecreting tumors of the adrenal cortex. Presentation. Cushing syndrome has high morbidity and mortality. Clinical features include moon phases, truncal obesity, hypertension, menstrual disturbances, striations and bruising, osteoporosis, lethargy, depression, hirsutism, acne, pigmentation, diabetes mellitus, feminization in males, polyuria, polydipsia, and psychosis. Management. Stop or minimize the exogenous steroids because 80% cases are because of exogenous steroids. And if it is not because of exogenous steroids, if no exogenous steroids is present as the etiology, then Cushing syndrome is suspected, that is primary suspected, and requested dexamethasone suppression test. Dexamethasone 1 milligram PO at midnight, then serum cortisol is measured at 9 am. If you are giving an exogenous steroid, then adrenal cortex should decrease the production of endogenous steroids. So if less than 50 millimoles per liter, it excludes the diagnosis unless cortisol secretion is episodic. If more than 50 millimoles per liter, then you have to check for secondary Cushing's, that is whether there is a high ACTH level and a 24-hour urinary free cortisol, and seek expert advice. Adrenal insufficiency. Addison's disease may be primary, resulting from adrenal disease or failure, or secondary, resulting from inadequate pituitary or hypothalamic stimulation of the adrenal glands. In the UK, most cases result from autoimmune disease, surgery, cessation of therapeutic corticosteroids, or failure to increase steroid dose to cover the stress. Worldwide, the causes are TB and AIDS. Clinical features are tiredness, weakness, anorexia, pigmentation, buccal, paresis and new scar pigmentation, weight loss, abdominal pain, myalgia, arthralgia, postural hypotension or fainting, and nausea. While in Cushing's there is hypertension, in Addison's there is hypotension, postural hypotension. Presentation. It can be a dramatic presentation with coma or severe hypoglycemia in a crisis state, or insidious presentation. 50% patients with autoimmune Addison's disease will develop another autoimmune disease like Graves' disease, pernicious anemia, and 5% of women develop premature ovarian failure. Short synactin test. Take a 9 am blood serum for serum cortisol levels. Inject 250 micrograms of synactin, synthetic ACTH, IV or IM. Take a further blood sample for serum cortisol levels half an hour later. If 30 minutes cortisol level is more than 600 nanomoles per liter, adrenal insufficiency is excluded. 400 to 590 nanomoles per liter, the result is equivocal, repeat the test. Less than 400 nanomoles per liter, adrenal insufficiency is confirmed. Check ACTH levels. If decreased, investigate pituitary function. If increased, investigate cause of adrenal disease. So this is more clear. Short synactin test to determine whether there is actual adrenal insufficiency is there, and in case adrenal insufficiency is confirmed, then you have to check the ACTH levels, and if ACTH levels are high but still adrenal gland is not able to produce hormones, then it's an adrenal cause, and if ACTH level is low, then you need to investigate pituitary function. Other investigation: biochemical abnormalities. In adrenal insufficiency, there will be increased potassium, decreased sodium, decreased glucose, may not be symptomatic, uremia, increased calcium, and abnormal LFTs. So, in adrenal cortical deficiency or Addison's disease, there is decreased mineralocorticoids and glucocorticoids. So, serum glucose levels will be low. Mineralocorticoids or aldosterone is low. When aldosterone is not there, then sodium will not be reabsorbed. So, there is reduced sodium in the blood, and when sodium is not reabsorbed, there is increased potassium excretion. Uh, the increased potassium retention. So potassium is more. There is hyperkalemia, hyponatremia, decreased glucose, uremia, increased calcium, and abnormal LFTs. FBC, there will be a normocytic anemia, eosinophilia, and lymphocytosis. Management. Refer to endocrinology. Urgency depends on the clinical state. Treatment usually involves replacing deficient steroids with hydrocortisone and fludrocortisone. Warn patients not to stop steroids abruptly, to tell any doctor treating them about their condition, and wear a Medi-Alert Meditag bracelet in case of emergency. Double dose hydrocortisone prior to dental treatment or intercurrent illness in URTI. So you need to double the dose of glucocorticoids, that is hydrocortisone, during any dental treatment or intercurrent illness. If vomiting is present, replace hydrocortisone perorally with IM hydrocortisone. So in case patient is not able to retain hydrocortisone orally due to vomiting, then give by IM injection. Hyperaldosteronism. This is a state where there is excessive aldosterone, suggested by the presence of increased high BP. So, hyperaldosteronism, there is hypertension, which is resistant to treatment, together with there is decreased potassium, because when aldosterone is more, sodium is retained and potassium is lost. So, there will be hypokalemia. But normokalemic cases are also described. Maybe primary, 2 out of 3 have aldosterone secreting adenoma, when termed Conn syndrome, or secondary due to excess renin secretion, example due to renal artery stenosis. So, primary hyperaldosteronism, also called as Conn syndrome, when there is an aldosterone secreting adenoma, or secondary due to excess renin secretion, example due to a renal artery stenosis. There is increased renin secretion, and then renin secretion causes increased aldosterone. If suspected, refer for endocrine assessment. Treatment depends on the cause. Rarely, excess licorice consumption can mimic Conn syndrome. Congenital adrenal hyperplasia will be described in page 873. Disorders of the adrenal medulla. Pheochromocytoma, rare but serious disorder affecting 0.1% of the hypertensive patients, usually caused by catecholamine secreting tumors. 10% are bilateral, 10% are extraadrenal, and 10% occur in children. 10% are malignant. May present with a huge area of symptoms and signs. High BP may be sporadic or sustained. Suspect in a patient who are young with high BP, are very labile BP or sudden onset hypertension is there, have a high BP and associated with headaches, sweating or palpitations, have other associated conditions like neurofibromatosis. So in these cases you have to suspect there might be a pheochromocytoma, which is the reason for hypertension in these patients. Check 24-hour urinary catecholamine or metabolite levels, follow laboratory protocol. If confirmed or strong suspicion is there, despite a negative test, refer for specialist opinion. Treatment is usually surgical if a tumor is found. Pituitary problems. Hypopituitarism. Production of all pituitary hormones, that is ACTH, growth hormone, FSH, LH, TSH and prolactin will be decreased. Causes are iatrogenic, surgery or irradiation, infection due to TB. Tumor may be a non-secreting or secreting primary pituitary non-secreting, or can secrete one of the pituitary hormones with decreased secretion of the others. When a tumor is present, could be secreting or non-secreting, and when secreting it can produce one hormone but can not secrete other hormones. Sheehan syndrome, pituitary necrosis following postpartum hemorrhage. Presentation of pituitary failure or hypopituitarism. There will be hypothyroidism, hypogonadism, anorexia, headache, depression, hair loss, hypotension and visual field defects. Management. If you suspect You should refer to neurology or endocrinology for further investigation and advice on treatment. Pituitary tumors. 10% of the intracranial tumors, almost all are benign, classified by histological type, chromophobic, eosinophilic, basophilic, or by hormone secreted. When there is no hormone secreted in 30% cases, prolactinoma 35%, growth hormone 20%, ACTH is secreted in 7%, prolactin and growth hormone together in 7% cases, LS, FSS and TSH in 1% of the cases. Presentation. So present with symptoms caused by local pressure, bitemporal hemianopia, cranial nerve palsies, headache, hormone secretion and or hypopituitarism. See earlier in this topic. So presentation would be because of hypopituitarism or hormone secretions, whether some hormones are not secreted or higher, maybe increased secretion is there like prolactinomas. Local pressure. When there is local pressure on the optic chiasma, bitemporal hemianopia might be the presenting symptom or could be cranial nerve palsies or headache depending upon the involvement in the brain. Management. If suspected, refer for a specialist management. Pituitary apoplexy. Rapid expansion of the pituitary tumor due to infarction or hemorrhage. Suspect if sudden onset headache in a patient with known pituitary tumor. Admit as a medical or neurosurgical emergency. Craniopharyngioma. The tumor originating from the Rathke's pouch. 50% of the patients are children with local pressure effects. See the pituitary tumors. Refer as for pituitary tumors. So here also they will be having bitemporal hemianopia. Hyperprolactinoma anemia. The most common pituitary disorder resulting from pituitary adenoma or prolactinoma. Presentation tends to present earlier in females than in males. Symptoms are due to pressure effects or increase in prolactin. Symptoms of increased prolactin are in females loss of libido, weight gain, apathy, vaginal dryness, menstrual disturbances, infertility and galactorrhea. In males it is impotence and reduction in facial hair. Investigation. Check for a basal plasma prolactin level. Ask the laboratory for conditions under which they would like the sample to be taken. Other causes of raised prolactin are pregnancy, breastfeeding, stress, sleep, hypothyroidism, drugs, phenothiazines, metoclopramide, domperidone, SSRIs, methyl-dopa and estrogens. So make a note of these drugs. These are phenothiazines, metoclopramide and domperidone, the antiemetics, SSRIs, methyl-dopa and estrogens. Most common causes are metoclopramide and domperidone. And chronic kidney diseases and sarcoidosis. Management. Exclude other causes of raised prolactin. If no obvious other cause is present, suspect a prolactin secreting pituitary adenoma and refer for specialist management. So hyperprolactinemia, you have to rule out all of these conditions first, the other causes, and if other causes are ruled out, then only you need to check for a suspecting a prolactin secreting pituitary adenoma and then refer for specialist opinion. Acromegaly, a rare condition due to growth hormone secreting pituitary tumor. Typical age of presentation is 30 to 50 years. Presentation is local pressure symptoms, changes in appearance of the face, coarse oily skin, change in facial appearance with coarsening of features, increase in foot size and increase in teeth spacing. Other effects are deepening of the voice, sweating, paresthesias, proximal muscle weakness, progressive heart failure and goiter. Complications of acromegaly include diabetes, high BP, cardiomyopathy, large bowel tumors. Investigations are Investigations and management. Check the growth hormone levels. Refer to endocrinology. Diabetes insipidus. Caused by impaired water reabsorption by the kidneys. Two mechanisms. Cranial diabetes insipidus. There is decrease in ADH secretion from the posterior pituitary. 50% idiopathic. Other causes are head injury, tumor, infection, sarcoidosis, vascular or inherited. Decreased ADH secretion due to either there is decreased secretion from posterior pituitary due to head injury, tumor, infection, sarcoidosis or vascular inherited. Nephrogenic diabetes insipidus, impaired response of the kidney to ADH. Causes are drugs. Lithium is a cause of nephrogenic diabetes insipidus. Hypercalcemia, pyelonephritis, hydronephrosis. Pregnancy is a rare cause of nephrogenic diabetic insipidus. Presentation. is polydipsia, polyuria, dilute urine and dehydration. Investigations. Urea and electrolytes. Sodium is often high. Plasma and urine osmolarity. Plasma osmolarity is increased, urine osmolarity is decreased, ratio is more than 1. Specialist investigations. Water deprivation test to confirm the diagnosis. So there is raised plasma and urine osmolarity and plasma and urine osmolarity we have to check. There is dilute urine even though there is a concentrated plasma, and plasma to urine osmolarity ratio is more than 1. Management. Treat the cause. Renal diabetes insipidus may be treated by intranasal desmopressin or surgery. Nephrogenic diabetes insipidus may be treated with dietary restriction of protein and salt or bendroflumethiazide. Management. Treat the cause. Renal diabetes insipidus may be treated with intranasal desmopressin spray or surgery. And nephrogenic diabetes insipidus may be treated with dietary restriction of protein and salt and or bendroflumethiazide, or which is a thiazide diuretic. Syndrome of inappropriate ADH or CRD is important cause of hyponatremia. Diagnosis is made by finding a concentrated urine, sodium more than 20 millimoles per liter, in the presence of hyponatremia, that is less than 125 millimoles per liter, or low plasma osmolarity, less than 260 millimoles per kg, in the absence of hypovolemia, on edema or diuretics. So basically, whenever there is a dehydration, the body tends to retain salt, and whenever there is hypoosmolarity in the plasma, low osmolarity, then the body tries to excrete more water, retain more salt. So in CRD, there is a tendency for diuresis. There is excessive ADH and there is tendency for diuresis. So diagnosis is made by finding a concentrated urine, sodium concentration of 20 millimoles per liter in the presence of hyponatremia less than 125 millimoles per liter, or low plasma osmolarity less than 260 millimoles per kg, in the absence of a hypovolemia, edema or diuretics. Always requires a specialist management. Causes could be malignancy, small cell lung cancer, pancreas, lymphoma. CNS disorders, example stroke, subdural hemorrhage or vasculitis. Either it could be malignancy or a CNS disorder. That is why always requires a specialist management. So our next topic is, we are at page number 343. We are in gastrointestinal medicine. Gastrointestinal medicine. Assessment of abdominal pain. Signs may be unclear in elderly patients, children and those on steroids. History is consider the site of the pain, as in figure 12.1. Onset, how long, how did it start and did it change over time? Like Socrates, Socrates is a site, onset, character of pain, colicky pain comes and goes in waves, results from GI obstruction, renal biliary colic, gastroenteritis or IBS. Radiation, is there any radiation of the pain? A, associated symptoms, nausea, vomiting, diarrhea. T, timing or pattern, example, constant colicky, relationship to food, exacerbating or relieving factors, including previous treatments tried and severity. Examination. Temperature, pulse, BP, respiratory rate. So vitals, anemia or jaundice is present. Abdomen, the site of pain. Guarding or rebound tenderness is present. Rectal or vaginal examination as needed. Consider a urine dipstick, finger prick blood glucose testing as needed. So after doing a local examination, then you can consider doing a urine dipstick test for infection and a finger prick glucose test if there is other causes of abdominal pain like diabetes ketoacidosis. Management: treat the cause. If acute or subacute onset severe pain, admit as a surgical emergency to hospital. Differential diagnosis of abdominal pain. Renal causes or urological causes could be renal colic, UTI, pyelonephritis, urinary retention, hydronephrosis, torsion of the testes. Gynecological causes: it could be an ectopic pregnancy, dysmenorrhea, endometriosis, pelvic inflammatory disease, ovarian torsion, ovarian cyst or bleed or rupture, gynecological malignancies. Gastrointestinal causes could be surgical or medical. Surgical could be a perforated bowel, bowel obstruction, intussusception, strangulated hernia, volvulus, appendicitis, Meckel's diverticulum, gallbladder disease, pancreatitis, GI malignancy, Henoch-Schönlein purpura. Medical: gastritis, peptic ulcer disease, gastroenteritis, Crohn's or ulcerative colitis, IBS, irritable bowel syndrome, constipation, diverticular disease or liver disease. Other intra-abdominal causes could be sickle cell crisis, ruptured spleen, leaked aortic aneurysm, ruptured aortic aneurysm, mesenteric ischemia, mesenteric adenitis, subphrenic abscess. Metabolic causes could be diabetic ketoacidosis, porphyria, Addison's disease, or lead poisoning. Other extra-abdominal causes: shingles, post-herpetic neuralgia, spinal arthritis, muscular pain, MI, CCF, or pneumonia. So, assessment of abdominal pain, these are the quadrants. So, whenever there is right upper quadrant pain, it could be liver related, gallbladder related, duodenum, or right lung. Left upper quadrant pain could be stomach related, spleen related, or left side lung related. Epigastric pain, esophagus related, stomach related, duodenum, or heart. Right loin pain, right kidney, colon, ureter, and musculoskeletal. Left loin pain, left kidney, colon, ureter, but there is one extra thing, that is abdominal aorta and musculoskeletal. Central abdominal pain or umbilical pain, small bowel disease, appendix, Meckel's diverticulum. Right iliac fossa pain could be due to cecum, appendix, right ovary, right fallopian tube, or ureter. Left iliac fossa pain, colon, left ovary, left fallopian tube, and ureter. Suprapubic pain could be due to bladder, uterus, or rectum. Pelvic pain, page 690. Anal pain or perianal pain. Treat the cause. Consider whether there could be an anal fissure, hemorrhoids, perianal hematoma, thrombosed bile, perianal abscess, anal or perianal fistula, pilonidal sinus, skin infection, hidradenitis suppurativa, functional pain, proctalgia fugax, rectal or anal carcinoma. Tenesmus, sensation of incomplete rectal emptying following defecation, as if something has been left behind which cannot be passed. Common in irritable bowel syndrome, can also be caused by proctitis or inflammatory bowel disease and tumor. Abdominal migraine or periodic syndrome, seen in children, presents as stereotypes attacks in which nausea and vomiting and headache accompanied by abdominal pain. Treat as for migraine. Some of these children develop classical migraine later on. So, abdominal pain may be and bilateral headache with weak presentation of migraine in children. Vomiting and diarrhea. Most episodes of acute vomiting and diarrhea are due to viral infection, short-lived, 2 to 5 days, and self-limiting. Nausea, unpleasant symptom. The patient feels as if he or she might vomit. Most conditions which cause vomiting can also cause nausea. Vomiting. Common symptoms are given here, table 12.2. History. Duration of vomiting, ability to retain food or fluids, relationship to eating, nature of vomiters, presence of blood or coffee ground, bilious vomiting, sources of infection like food exposure, reheated rice, uncooked chicken, foreign travel, any contacts with similar symptoms, other associated symptoms. Example, fever, if whether there is any fever, abdominal pain or diarrhea along with vomiting. Other illnesses like diabetes, mellitus, Meniere's disease, migraine or cancer. Medications example opioids and chemotherapy. Examination. Assess the hydration status first. Check the BP and pulse rate, dry mouth, reduction in skin turgor, sunken eyes or sunken fontanelle in babies are all late signs. Abdomen examination, whether there is any mass, distension, tenderness or bowel sounds are present or not. For children, look for other sources of infection, example ENT, chest and UTI. Slimy stool, caused by overproduction of mucus in large bowel, almost always associated with colonic disease or irritable bowel syndrome. Investigate unless all other features are typical of IBS and age is less than 40. Diarrhea. Establish what the patient might mean by diarrhea. Diarrhea is an abnormal passage of loose or liquid stools causes mentioned in table 12.2. History in the history of diarrhea, duration termed as chronic if persists beyond 4 weeks, nature of diarrhea, color, consistency, whether there is blood or mucus, contact with anyone else with similar symptoms, occupation or a travel history, associated symptoms, example, fever, abdominal pain, vomiting or weight loss is present. Association with other factors, food intolerance and weight and stress. Past medical history, surgery, especially the ileal resection or cholecystectomy, pancreatic disease, systemic disease, diabetes or thyrotoxicosis, family history, inflammatory bowel disease or celiac disease, or family history is present, bowel cancer, alcohol consumption, high intake is associated with diarrhea, medication, example antibiotics, regular medications, 4% of chronic diarrhea. Examination. Assess the hydration status. Check the PP pulse rate. Again, dry mouth, reduction in skin turgor, sunken eyes, sunken fontanelle. Abdomen, if there is any masses, distension, tenderness, or bowel sounds are present or not, and stool. As examination. Assess the. So we have done the examination, hydration status, and the abdomen examination. Investigation. Send a stool sample for microscopy, culture sensitivity if any of the following is present. Fever, blood in the stool, food worker, recent return from a tropical climate, immunocompromise, resident of an institution, and if diarrhea persists more than 7 days. Not all the diarrhea you have to send for stool sample. Only you have to send a stool sample whenever there is fever, that is it's an infectious diarrhea, when there is blood in stool, that is it is dysentery, whether when he is a food worker and there is a possibility that he will spread the infection to other people. Recent return from a tropical climate, we have to check out for traveler's diarrhea. Immunocompromise if present, that may compromise the patient. Resident of an institution, again there is a chance that the infection might spread to others or has been spread to him by others, and if it persists more than 7 days. Causes of vomiting and diarrhea. Vomiting. Physiological causes, example, positing in babies, travel or motion sickness, GI infection, viral gastroenteritis or food poisoning, other infections, particularly in children, tonsillitis, otitis media, other GI causes, GI obstruction, pyloric stenosis, cow's milk protein allergy, acute abdomen, CNS causes, raised intracranial pressure, head injury, migraine and vertigo, metabolic causes, whether there is pregnancy, uremia, ketoacidosis, psychiatric causes, anorexia and bulimia, malignancies, drug and toxins, alcohol, opioids, cytotoxic agents. These all cause vomiting. Diarrhea, acute diarrhea, dietary indiscretion, infection, food poisoning, traveler's diarrhea, constipation with an overflow, pseudomembranous colitis, recent history of oral antibiotics, onset of inflammatory bowel disease or other chronic diarrheas. Chronic diarrheas we'll read in page 379. Management of acute diarrhea or vomiting. Treat any unidentified cause of diarrhea or vomiting. Treat any identified cause. So if you can identify the cause, you treat it. Rehydration. Encourage clear fluid intake, small amounts frequently, plus rehydration salts. Use commercial preparation like dioralite. Food. Stick to a bland diet avoiding dairy products until symptoms have settled. Babies who are breastfed or have not been weaned should continue their normal milk. If dehydrated and unable to replace fluids, diarrhea with concomitant vomiting, or child or elderly person refusing to drink, admit them. So if dehydrated and unable to replenish the fluids, then admit them. Never give children antidiarrheal agents. Never give children antidiarrheals. Antidiarrheals are, for example, Imodium, loperamide. If no cause is found and diarrhea lasts more than 4 weeks or any atypical features are present, consider referral for urgent investigations as mentioned in page 378 because more than 4 weeks is chronic diarrhea. Hematemesis, we will see in 1061, fecal incontinence, chronic diarrhea and malabsorption, malignant or rectal bleeding, gastroenteritis, factitious diarrhea. Some children may become cow's milk intolerant after a burst of gastroenteritis, that is temporary lactose intolerance. Think of hemolytic uremic syndrome in any child with diarrhea who passes blood in stools. Okay. This is associated, hemolytic uremic syndrome is associated with hematuria and decrease in urine volume. Gastroenteritis and food poisoning. Ingestion of viruses, bacteria or the toxins commonly cause diarrhea or vomiting. Suspected food poisoning is a notifiable disease. Prevention. Hand washing after using the toilet. Longer cooking and rewarming times. Prompt consumption of food. Presentation. Common causes table 12.3. History. Severity. Yeah, we have seen the common causes of gastroenteritis, both diarrhea and vomiting in the table. So what is the presentation? History, severity and duration of symptoms. You have to ask food eaten, water drunk, time relationship between ingestion and symptoms and other affected contacts, recent foreign travel. Examination usually normal. Dehydration may prompt an admission. Investigations and management. See vomiting and diarrhea. Okay, 346. Advise fluid replacement. Only give antibiotics if recommended following a stool culture, except for giardia diarrhea. So, in normal vomiting and diarrhea, advise only fluid replacement. Antibiotics only when you have recommended stool culture. Campylobacter. Most common bacteria cause of infectious diarrhea in the UK is Campylobacter. Okay. C. jejuni or C. coli are responsible for most cases. Symptoms occur 2 to 5 days after ingestion of infected food, usually milk or poultry. Malaise followed by abdominal pain and diarrhea, often bloody diarrhea. Rarely associated with arthritis, usually clears spontaneously. If needed, treatment is to be given. Then erythromycin or ciprofloxacin are the antibiotics of choice. Salmonella, cause of infectious diarrhea, usually ingested in infected meat, poultry or eggs. Again, Campylobacter and Salmonella both by infected poultry or eggs. Symptoms are vomiting, diarrhea, abdominal pain and fever develop from 12 hours to 2 days, like 12 to 48 hours after ingestion, rarely associated with arthritis in 2 to 3 weeks after an acute infection. In less than 1%, a carrier state develops, usually only use antibiotics on microbiologist advice. That is after a culture. Escherichia coli. Many different strains of E. coli cause diarrhea via a variety of mechanisms. In most cases, treatment is supportive with fluid replacement. Rarely for enterohemorrhagic strains, antibiotics may be recommended, but use is controversial as antibiotic treatment has been linked with hemolytic uremic syndrome. Okay, so rarely, whenever antibiotic is given, its use is controversial as it has been linked with hemolytic uremic syndrome in E. coli diarrheas. Cryptosporidium is a protozoan causing diarrheal disease. Infections are usually spread in water, responsible for 5% of all gastroenteritis in both industrialized and developing countries. Presents with profuse watery diarrhea. abdominal cramps, nausea, anorexia, fever, and malaise. Treatment is supportive. Usually, symptoms last 1 to 2 weeks, rarely more than a month. Immunocompromised patients develop profuse, intractable diarrhea, which is difficult to clear and may continue intermittently for life. Cryptosporidium. Norovirus, winter vomiting virus. There have been some questions regarding this in the past medicine. Uh, Most common cause of infectious gastroenteritis in the UK. Okay. Particularly in communal settings, example in the schools, hospitals, illness is generally mild, lasts 2 to 3 days, and there's no long-term side effects. Infections can occur at any age because immunity is not long-lasting. Scrupulous hygiene is needed to contain the outbreaks. So, winter vomiting virus or norovirus, most common cause of infectious gastroenteritis in UK. So we have a table here, common cause of gastroenteritis in the UK. So let us try to grasp some points. So Bacillus cereus, within 1 to 5 hours, it is a food poisoning. Preformed toxin will be there mainly by preheated rice, like fried rice, and diarrhea and vomiting are the important symptoms. Campylobacter jejuni, 48 hours to 5 days. Diarrhea, pyrexia, I think. F is, let us see what is the key. Yeah, P is abdominal pain and F is fever. So in Campylobacter jejuni infection, so there will be fever, there will be abdominal pain and diarrhea. There is no vomiting. It's blood in the stools and caused by milk and poultry. Clostridium botulinum, 12 to 36 hours, causes paralysis due to canned food. Clostridium perfringens, 6 to 24 hours, causes diarrhea and pain abdomen due to meat. E. coli, 12 to 72 hours. There's blood in the stool because hemorrhagic diarrhea and diarrhea, pain abdomen and fever. Food and water are the causes. Salmonella species, 12 hours to 48 hours. All the four, diarrhea, vomiting, pain abdomen, fever due to meat, eggs and poultry. Shigella, 48 to 72 hours and there is blood in the stool and caused by any food. There is no vomiting. Staph aureus 1 to 6 hours again. Bacillus cereus 1 to 5 and staph is 1 to 6. Again there is a preformed toxin in here. So is due to meat. That is not properly heated meat. Properly cooked meat. Staph aureus diarrhea causes reduction in blood pressure. Vibrio parahemolyticus 12 to 24 hours is because of fish. Yersinia enterocolitica 24 to 36 hours. Again it is because of milk and water. Giardia lamblia 1 to 4 weeks. It's a protozoan. It only causes diarrhea because of water, infected water. Entamoeba histolytica 1 to 4 weeks causes diarrhea, pain abdomen and fever. Blood in the stool, food and water. Cryptosporidium 4 to 12 days. Diarrhea, pain abdomen and fever because of water again. Listeria monocyte. Listeria causes flu-like illness, pneumonia, miscarriage because of milk products, uh, pates, raw vegetables. Norovirus 24 to 48 hours, most common cause of winter vomiting illness. So there is diarrhea, vomiting as well as fever. Malaise, food and water are the causes. Rotavirus 1 to 7 days causes fever, diarrhea, vomiting and fever. Malaise, food and water are the most important causes. Mushrooms 15 minutes to 24 hours. It causes fits, coma, renal failure, liver failure. Okay, some toxic mushrooms. Scrombotoxin 10 minutes to 60 minutes. Flushes, erythema because of the fish, causes diarrhea. Heavy metals zinc 5 minutes to 2 hours causes vomiting as well as pain abdomen. It's a very extensive list. Try to remember as much as you can. Try reading again and again so you'll remember more. Rotavirus, most common cause of gastroenteritis in children. Most are immune by 5 years. Presence with malaise, abdominal pain, diarrhea and vomiting. Common cause of hospital admissions in infants. Treatment is supportive. Babies in the UK are offered rotavirus vaccination within the childhood immunization program. Some children may become cow's milk intolerant after a bout of gastroenteritis. So, rotavirus vaccine is given on the second and third month because that is the peak onset of rotavirus diarrhea. So, one dose oral rotavirus vaccine in the second month and third month. Gastrointestinal medicine. Next topic is constipation, page number 350. 3 million GP consultants in the year UK result from consultations in the year in the UK result from constipation. Differentiate normal stools a few days apart and normal no needs treatment and infrequent stool or hard stool suggest constipation. Definition: two or more of the following for more than 3 months. Straining at defecation less than 25% of the time. Sensation of incomplete evacuation less than 2 bowel movements per week. Lumpy or hard stools more than 25% of the time. Most patients consulting in general practice do not meet this criteria. So there should be 2 or more of these criteria for more than 3 months for defining it as a constipation. Children with constipation. Page 866 we will see there. Young patients less than 40 years with lone constipation. Females to male ratio is 9:1. Established symptoms. Constipation usually long-standing in this group include drug and diet history. Ask about health beliefs. 80% people believe the bowel should be opened daily. Explore concerns about underlying disease. If long-standing, ask why the patient is consulting now. Examine the abdomen. Investigate if symptoms or signs suggest of organic disease is present, as in table 12.4. Management. Treat organic causes, otherwise give lifestyle advice. Increase the fluid intake to less than more than equal to less than equal to 2 liters per day, 8 to 10 cups. Avoid alcohol. Increase exercise if possible. Add a fiber to the diet. Increase fruits and vegetables. Eat whole grain foods and add bran or oats. Open bowel when needed. If a lifestyle advice fails and symptoms cause distress, start a bulk forming laxative like isafgula husk. Avoid in opioid constipation. If this fails, try an osmotic laxative like macrogol or magnesium hydroxide 15 ml BD. So first line is isafgul, second line is an osmotic laxative. If an osmotic laxative also fails, try short course of stimulant laxative. Example, Senna 1 to 2 tablets at 5 pm, either alone or in combination with an osmotic laxative. Long-term use of some stimulant laxatives is reported to cause catharic atonic colon. Although this is unlikely in the young, fit patients only use short courses or use intermittently. Example, twice weekly. If still constipated, specialist referral is warranted. Organic causes of constipation, table 12.4. This is also an extensive one. Let us see. Colonic disease. Colonic diseases causing constipation are carcinoma, whether there is a diverticular disease, Crohn's disease, stricture, intussusception, or volvulus. Anorectal disease, anterior mucosal prolapse, distal proctitis, anal fissures, perianal abscess. Pelvic disease, when there is an ovarian tumor, uterine tumor, or endometriosis. Endocrine or metabolic disorders, hypercalcemia, hypothyroidism, diabetes with autonomic neuropathy. Drugs, opioids, antacids containing calcium or aluminium, antidepressants, iron, antiparkinsonian drugs, anticholinergics, anticonvulsants, antihistamines, calcium antagonists. Others are iron, others are pregnancy, immobility, poor fluid intake. Irritable bowel syndrome with constipation. So irritable bowel syndrome has both diarrhea and constipation. Sometimes it can be constipation predominant and sometimes it can be diarrhea predominant. 20% develop symptoms of IBS in their lifetime. Constipation is the predominant symptom in 30%, but other symptoms are usually present. Established symptoms. Examine the abdomen. Investigations include FBC, CRP, TTG, tissue transglutaminase to exclude other organic causes of constipation, because IBS is a diagnosis of exclusion. You have to exclude every other organic cause to think that is functional. Irritable bowel syndrome. Management, if less than 40 years, examination investigations are normal, fulfills the IBS criteria as in page 388. Manage as for young patients with lone constipation, but avoid osmotic laxatives as they make bloating worse. So this is one point and has been tested in the exam. Avoid osmotic laxatives as they make bloating worse. So you will not give magnesium hydroxide. You will give either isofgol husk or you will give stimulant laxatives. Constipation in the over 40s. Any sustained change in bowel habit for more than 6 weeks should be seriously taken and investigated if appropriate. Establish symptoms and onset. Specifically ask about tenesmus, blood in the stool, abdominal pain and diarrhea. Check current medication. Examine the abdomen for masses and hepatomegaly. Rectal examination is essential to exclude low rectal or anal carcinoma and detect fecal impaction. So, whenever constipation is present in less than 40 years, it's okay, but whenever it is over 40 years and sustained change in bowel habit more than 6 weeks, it should be taken very seriously as it could be the only marker for cancer management, only symptom of cancer management. Check FBCs, ESR, renal function, LFTs, TFTs, and serum glucose. TFTs because hypothyroidism can cause constipation. LFTs you have to check serum glucose levels also. Image the lower bowel by colonoscopy or CT colography if new symptoms that persist more than 6 weeks. Treat any reversible or underlying organic cause. Give lifestyle advice. See management of constipation less than 40 years. So lifestyle advice you have to give. Treat symptomatically if no cause is found and cause is untreatable. Laxatives, consider bulk forming laxative like isabgula or osmotic magnesium hydroxide plus a stimulant laxative. Titrate the dose to response. Long term use of stimulant laxatives including co-dantrosate is acceptable in very elderly. So very elderly you can give long term stimulant laxatives. Otherwise use PRN or intermittently. If oral laxatives are ineffective, consider adding rectal measures. If soft stool, try bisacodyl suppositories. Must come into direct contact with the rectum. If hard stools, try glyceride suppositories. Act less than 1 to 6 hours. If still not cleared, fecal impaction is present, refer to district nurse for lubricant plus high phosphate stimulant enema acts in less than 2 minutes. So, if oral laxatives are not effective, then rectal suppository you give, and you give if stools are soft, you give bisacodyl suppositories. If stools are hard, you give glycerol suppositories, and still the stool is not cleared or there is a fecal impaction, you refer to a district nurse. So then for lubricant plus high phosphate stimulant enema, then their nurse will give enema. Once constipation has been cleared, leave the patient with clear instructions about what to do if symptoms recur. High risk patients. Example, patient on opioids, those who are immobile or have medical conditions which predispose them to constipation. Pre-exempt constipation by putting high risk patients on regular aperients. See, when patient is taking opioid, so they are vulnerable or they are immobile or have medical conditions, then preempt constipation by putting high risk patients on regular aperients. Give them prophylactically, you give them medicine for preventing constipation. Occult presentations of constipation are common in the elderly, include confusion, urinary retention, abdominal pain, overflow diarrhea, or loss of appetite and nausea. These are the occult presentations. Other abdominal signs and symptoms: dyspepsia, abdominal distension. Consider abdominal or pelvic mass, and whenever there is an abdominal distension, consider either there is an abdominal or a pelvic mass, and either there might be a fluid, ascites, or full bladder, whether there is fat, feces, flatus, intestinal obstruction or air swallowing, fetus, food, example malabsorption. Abdominal masses. Distinguish from pelvic mass by ability to get beneath them. Causes are malignancy, any intra-abdominal organ or kidney, stool, abdominal aortic aneurysm, hepato or splenomegaly, appendix mass or abscess, Conn's mass, lymph nodes or TB. A hernia may be present as a mass in the abdominal wall, groin lump. Pelvic masses causes are fetus, there can be a full bladder, They can be fibroids, gynecological malignancy, bladder cancer, etc. Splenomegaly causes are hematological causes like lymphoma, leukemia, myeloproliferative disorders, sickle cell disease, and thalassemias. Inflammatory causes of splenomegaly are rheumatoid arthritis, Sjogren's syndrome, sarcoids, or amyloid. Infections are glandular fever like infection mononucleosis, malaria, subacute bacterial endocarditis, TB, leishmaniasis. So, glandular fever, malaria, TB, leishmaniasis, or SBE. Hepatomegaly causes are apparent when there is a riddle slope, low-lying diaphragm. Tumors, secondary, most common cause, primary. Secondary is most common and primary tumor can be there. Venous congestion when there is a heart failure or hepatic vein obstruction. Hematological leukemia, lymphoma, myeloproliferative disorders, and sickle cell disease. When there is a biliary obstruction, particularly extrahepatic biliary obstruction. Inflammation, hepatitis, abscess, schistosomiasis. Metabolic, fatty liver, amyloid, glycogen storage disease. Cysts, polycystic liver disease or hydatid cyst. Ascites, free fluid in the peritoneal cavity. Signs, abdominal distension, shifting dullness to percussion, fluid fill will be there. Causes are malignancy, any intra-abdominal organ malignancy, ovarian cancer, renal cancer, hyperproteinemia. Example when there is nephrotic syndrome or there is a right heart failure, portal hypertension. Fistula, abnormal communication between one organ and another, usually due to cancer or complications of surgery. Presentation are in the table 12.5, refer urgently if suspected. So, bowel to skin fistula, fecal discharge to surgical wound, bladder to ureters to skin, bladder or ureter to skin, clear watery discharge which smells of urine, bowel to vagina, fecal material in the vagina, bladder to vagina, leakage of urine per vaginum, bowel to bladder, air or feculent material in the urine or recurrent urinary tract infections. So you need to refer urgently if you are suspecting any fistula. Refer for suspected GI cancer. Urgent referral to be seen within 2 weeks to a team specializing in upper GI cancer if upper abdominal mass consistent with stomach or pancreatic cancer plus age is more than 40 years and jaundice is present. To a team specializing colorectal cancer if any age plus anal ulceration, any age plus anal, rectal or abdominal mass, any age plus rectal bleeding plus unexplained abdominal pain, change in bowel habit, weight loss, iron deficiency anemia, any age more than 40, unexplained weight loss, abdominal pain, age more than 50, unexplained rectal bleeding, age more than 60, iron deficiency anemia, or persistent change in bowel habit or fecal occult blood positive. For upper GI endoscopy, if dysphagia is present, age 55 years or more, plus weight loss plus upper abdominal pain, reflux or dyspepsia. For direct access CT, ultrasound, CT scan if not available, if more than 60 years of age plus weight loss and more than one of the following is present. When there is diarrhea, back pain, abdominal pain, nausea, vomiting, constipation, new onset diabetes. For direct access ultrasound, if upper abdominal mass consistent with enlarged liver or gallbladder is present. For non-urgent referral, for upper GI endoscopy, if hematemesis or age more than 55 years with treatment-resistant dyspepsia or upper abdominal pain and decreased hemoglobin, increase in platelet count plus nausea vomiting, weight loss, reflex dyspepsia and or upper abdominal pain or nausea vomiting plus weight loss, reflex dyspepsia or upper abdominal pain. So increase in platelet count is an important thing here for non-urgent referral but referral for upper GI endoscopy. H. pylori status should not affect the decision to refer for suspected cancer. Consider checking the FBC to exclude iron deficiency anemia in all patients presenting with new onset dyspepsia. So today we will stop here, and we are at page number 354. We will continue tomorrow from page number 354, gastrointestinal medicine. Thank you. Have a good day.